All right, guys, welcome back to lecture. We are going to do laparoscopic prostatectomy. This is with or without robotic assistance. We're going to focus on with robotic assistance just because this is how most of these are done now. So what's our definition of a prostatectomy? We're going to remove the prostate gland through minimally invasive surgery approach with robotic assistance. So what is some surgical anatomy that we need to think about? We need to think about the prostate gland and the capsule that surrounds it, the seminal vesicles, the rectum is right there next to all this stuff, the penis, urethra, the bladder neck, and the bladder. And of course, why do we, not we as in all of us, but why do males have a prostate gland? It's to secrete seminal fluid into the urethra to help the viability of sperm as they travel out of the male urethra during ejaculation. So let's look at the blood supply of the prostate. The reason that the prostatectomies are so worrisome a lot of times is because our patients can actually lose a lot of blood with them. And as you can see, we have these giant vessels that come right into the prostate gland here, and they connect to all different parts of the prostate and actually run through the prostate. So the robotic approach has made this great because we can see all these little blood vessels, these big blood vessels, everything in here, and we can get it ligated and secured before we start cutting. But there is a high likelihood, a high probability that one of these may bleed, and so we need to make sure that our patient is always cross-typed and matched so that if we need blood products, they are available to us. The other thing we need to think about when looking at the prostate, so as we look at the prostate, this would be the penis here, this is the dorsal vein of the penis, this is the bladder up here, this would be the rectum, this is the prostate right here. So as we look at this, we can see there's a whole bunch of nerves that come into the prostate here, as well as the blood supply that comes in. And so before there were nerve-sparing prostatectomies, we would sweep all of this out from behind the prostate, and so our patient would lose a lot of these nerve endings as well as lose a lot of blood. Now with the robotic approach, we can see a lot more of these structures clearly. We can also get a better dissection back here because instead of doing a blind sweep, we can actually see behind the prostate and see what it is that we're ligating. And we can do a nerve-sparing prostatectomy, which means that our patients don't necessarily get rendered impotent just from having a prostatectomy. So why do we do a prostatectomy? Well, there are several reasons, the biggest one being prostate cancer. Most of the time, prostate cancer is the reason that we're having a prostatectomy. There is such a thing as a suprapubic prostatectomy, and that is for uncontrolled BPH, so benign prostatic hypertrophy. So if you remember, we do our PSA test, and if PSA is elevated, we go in and we biopsy. If it's benign, then we either do a TURP procedure or we just watch it. But some patients will actually allow their prostate to get so big that we can't even do a TURP on them. We can't get the scopes in and things because the prostate has grown so large. And so then we go in and we do a suprapubic prostatectomy, which means that we leave the capsule of the prostate so we're not disturbing any of those nerves or vessels, and remove the prostate just so that our patient can void again. But the most common is for prostate cancer in order to do a prostatectomy.